Okay, guys, let's talk about bicep tendon ruptures. With bicep tendon ruptures, we don't do a lot of surgery for a proximal bicep tendon rupture, but let's kind of review the anatomy and remind ourselves that we have the two heads of the biceps proximally, right? So the short head attaches basically onto the coracoid process, and the long head goes into the glenoid, right? So you can get tears to the long head of the biceps. We'll talk about those a little bit, but most of the time surgeries are going to occur to the distal attachment of the biceps, and you'll see that the distal attachment is on the radius. That's really, really, really important that we recognize the distal biceps attachment is on the radius. There's like a little medullary canal there that it attaches into, so it actually makes it pretty stable. But we'll talk about why we get tears there. But that's more kind of when we're talking about a surgery and we're talking about post-op, we're usually talking about distal bicep tendon. So it happens, and I guess, first of all, we need to, again, talk a little bit more about the anatomy. So the fact that it attaches where it does on the radius, it basically, when it contracts, the distal portion will cause, obviously, elbow flexion, but also supination. So it's really important where it is, it helps with supination. So as we're working through the rehab aspects of things, and kind of testing things as we think about precautions, we need to recognize that not only does the bicep do elbow flexion, which we all know, but it also is involved with supination. Usually when an injury is going to occur, it's going to happen because of some sort of eccentric contraction against a load. So the elbow's in a little bit of flexion, and you're trying to lift something up. And then it also will usually happen either in full supination or full pronation. And the reason that that's true is because when you go into full supination or pronation, the space is decreased by about 50% or more. So you get a closure of the space there in the canal. And so we're much more likely to get trauma and some sort of rupture. You can have like an acute injury, an acute tear with lifting, but you also can get micro trauma. So if somebody's doing a lot of supination, pronation with elbow flexion, then they may be getting micro trauma that then will lead to a tear eventually. It's also important to recognize that the distal biceps tendon does have a hypovascular zone, so there is an area where there's decreased blood flow. And so that area is oftentimes, again, we know that those areas more likely to have injury, but also it's going to be a lot harder for them to heal on their own because they don't have good blood flow that's already in the area. So if you injure your biceps, 3% of the time, you're going to rupture that distal tendon at the radial tuberosity. A large percentage of the people that actually do rupture their tendon, so 43%, are smokers. Okay, so 43% are smokers. Look at that. We're talking about smoking again. Big surprise. I'm sure you figured out we should not be smoking if we want things to heal correctly or not have the injury to begin with. Usually it's males, 40 to 50 years old, and usually, again, as I said before, it's usually with lifting. 60 to 80%, 61 to 81% occur on the dominant side. So probably the right side for most people in China. So different ways we can diagnose it. The hook test is kind of the most popular test to use for to see if there's a distal bicep tendon tear. And so what the patient's going to do, you'll see in the picture, the arm is outstretched with full supination. It's fully supinated. And there you're going to ask them to flex the arm, to flex the elbow. And then you're going to palpate the tendon in the antecubital fossa. So where we said it attaches on the radius. If you can't feel that tendon at all, then they might have torn it. And if it's a painful tendon when you palpate, then it could be a partial tear. There's also the O'Brien test, which can help to diagnose a bicep tendon tear. Remember, the muscle does supination as well as flexion. So because we have other muscles that do elbow flexion, usually the weakness and pain is more likely into supination than it is into flexion. So it's more likely they're going to have issues with supination than they will with flexion. Obviously, using things like a radiograph, ultrasound, MRI. Ultrasound and MRI are not used very often, but if they're really not sure and maybe they think they need surgery, then they're probably going to use them just to confirm. So non-operative treatment, almost all the time. So 96% of the time, you're going to do non-operative treatment if the long head of the proximal biceps is torn. Okay, so that's that tear. Again, that's why we're not going to really talk about the proximal bicep too much, because we have the short head, so we don't have to worry about it so much. They don't do surgery for that area very much. They also, for the distal biceps, may not do surgery for a partial tear, so just for a full tear. If they're choosing to go non-operatively, conservatively, they're going to immobilize for 3 weeks. And then you can start doing some flexion-assisted bracing for 3 weeks. And then you kind of change the activity and be conservative for 3 weeks. And then you can certainly do some of the rehab things that we're going to talk about probably in the second and third phase of the post-op time period if you want to. They will choose to do surgery with, again, most of those distal tears. It's unknown the best time to do a repair for those patients where it's a chronic problem. So we talked about how that area, that distal tendon, doesn't have good blood flow, and if they had little micro tears that ended up causing a full tear, you may not know about it, and so they may not know kind of if they should do surgery or when they should do surgery. So we're not sure what the best thing to do is with that one. The surgeons kind of have to just decide. But if it's an acute injury, if it's like a acute big tear, then they really should do it within 2 weeks of the injury, because especially if they wait 4 weeks after the injury, there's a lot more possibility of complications. They're going to pretty much always do surgery if they're extremely active patients. And if they're active and they're having a lot of symptoms, like where the bicipital groove is at the proximal biceps, okay? So proximal biceps, if they're having a lot of symptoms there, then they may choose to do surgery of the long head of the biceps. When they choose not to do surgery for distal ruptures, it's going to be when it's an older patient, they don't have a lot to do. Remember, again, elbow flexion can happen with 2 other muscles, so we can not do it if we don't want to. If they have a lot of comorbidities, so less likely to be able to heal well, or if it's a partial tear. Those are reasons they would not do surgery for a distal rupture. So the surgery, I'm not going to go into too much detail on this. It's basically, these surgeries for tendons often look pretty similar. What they found is if they move the tendon a little more posterior to the radial tuberosity, then they're actually going to get a better result. So they actually really do kind of change the position of the pull of the tendon when they reattach it. They could either do a 1 or a 2 incision technique. With the 1 incision, it sounds like there are more complications with the 1 incision, but then you'll see they're using a cortical button usually with that one. It's usually the safest and has the least amount of failure rates. With the 2 incision, then they're going to do a bone tunnel, which is what the picture shows here. They're usually going to secure kind of anchors into that bicep tuberosity through those bone tunnels. So this is just another picture. This is a distal, obviously the distal tendon. If it's really bad, just like with other tendons, they may end up using an autograft or an allograft. So they may end up going in, with tendon tissue from another tendon. If you remember, we talked about the rotator cuff. They might use the lats. the latissimus dorsi, they may do something like that here as well. Complications. Complication rate, I hate when they say things like 10 to 40% because that's a huge range. But you can see there is a complication rate for sure. The most common complication is going to be nerve palsy. So the area where they're doing this, again, this is the elbow, there's a lot of nerves around there. So when we talked about ossification problems, where you get that bony growth in the elbow, you can also, those complications are related to nerve. And for the bicep tendon surgeries, we also can end up with nerve injuries, usually to the posterior interosseous, maybe lateral antebrachial cutaneous nerve. Like I said earlier, there are more complications with that one incision anterior approach. So just keep that in mind. If you're just seeing one incision, you may have more likelihood of some nerve problem or other problem. Heterotrophic ossification, I told you guys that's usually a complication from something else. Unfortunately, that could be a complication of this surgery. And then range of motion deficits, which, not that many. 2% of the patients will have a greater than 30-degree range of motion deficit, flexion and extension. 2.6% deficit with supination and pronation. So not a huge amount. You should be able to get pretty good range of motion after these surgeries. So first phase following the surgery is going to last for about 3 weeks. And it's really all about controlling and protecting the attachment site. So they're going to put them in a brace. And again, this is for a distal bicep tendon repair. And our primary goal is to make sure that that is okay and we're controlling pain. For at least 2 to 3 weeks, they're going to use some sort of hinged brace that's adjustable, and they're going to put it at 90 degrees of flexion. So they're going to basically hold you in a little bit of a shortened position. If they have to do an allograft or an autograft, then they're going to put you in that brace longer, up to 6 weeks possibly. Yeah, you don't see this surgery very much. I've never seen an autograft surgery at all. But just to be aware of what that looks like. You also need to make sure that they stay in neutral supination pronation. Again, I think this is one of the things we forget that bicep does is that supination. So you've got to make sure you're keeping them in neutral so you're not putting it on stretch or strain. And no lifting, nothing against any type of resistance until week 6 to 8. So into the second and third phase. Our treatment at 2 weeks, for the first 2 weeks, you can really start doing, you really want to be doing passive range of motion, okay? From 0 to 90, you are not stretching that tendon. But from 0 to 90, you can do elbow flexion. You then can start increasing by 10 to 15 degrees per week. And you can do active elbow extension, okay? So extension obviously is fine. We just don't want active flexion. So it's active extension, passive flexion. You also can obviously move the shoulder as long as it's the distal bicep tendon, and you can do lots of gripping exercises. So lots of things, again, without doing active supination pronation, you can do gripping exercises at the hand. Starting at 3 weeks, you can start doing passive pronation and supination. So you are not even touching the idea of pronation and supination passively until 3 weeks. So this feels pretty conservative, right? And with this one, you can start advancing 5 to 10 degrees per week, okay? So passive range of motion for elbow flexion is okay as long as you're between 0 and 90. Supination pronation doesn't start until 3 weeks. For phase 2, we're going from weeks 4 to 6. And we still have to be careful of that attachment site, okay? During this period, we're really still focused on passive range of motion, but we're going slow with that passive range of motion. We're also going to be making sure that the shoulder and the wrist and hand have good range of motion. But again, when you think wrist hand, don't think supination, pronation. Just think flexion, extension, hand movements. You also want to be doing your goals are related to scar tissue, so you can think about manual therapy for that. We want to educate our patients not to put stress across the repaired tissue with passive mobility. So if you're giving them homework to do range of motion, you need to make sure that range of motion, that they're not stretching the tendon too much. So, some people stretching the scar tissue too much and stretching the tendon. That's true too. But you want to make sure that, if they're doing extension, that they're not like pushing it really hard into extension, or if there's scar tissue posteriorly or laterally, that they're not doing anything that would cause that scar tissue to have stress or strain. So treatment, you're progressing the passive range of motion. You can again continue with active elbow extension, but you're not doing any active flexion or supination until 6 weeks, okay? That's a long time, and it's really hard for patients to follow that, but you've got that brace. They should be wearing that brace, and you can, again, work on extension. You can work on the wrist hand stuff, and you can do passive, and you can progress passive so that you're getting passive range of motion as full range of motion. That's fine at this second phase. But you don't want them to be doing active flexion or supination until 6 weeks. You can be doing gripping exercises, and I would highly suggest gripping exercises, and then gentle scar tissue mobilization, which we kind of mentioned earlier. From 6 to 8 weeks is phase 3. So again, once they get into the third phase, they really have to be very, very careful for the first 6 weeks. Once they get into the third phase, now you can start doing more active range of motion. You can actually start doing strengthening as well. So you're checking active range of motion and actually progressing to strengthening here during this third phase. You do want to make sure the tissue mobility is good. Anybody who's ever worked, again, with patients with elbow injuries, you know that the soft tissue on the anterior aspect of the elbow can get really, really tight, really, really fast. So, we talk a lot about joint mobilization at the elbow, which is great, but if the soft tissue is tight, you're not going to be able to get any improvement until you get that loosened up, and then you can do joint mobilization. So passive stretching into extension is going to be really, really helpful. It's going to keep that tissue mobile. So as long as you're not messing up the scar, you want to be doing a lot of passive extension, and they can do active extension as well. But making sure that anterior, that tissue, that fascia is really, really mobile throughout their rehab. Flexion and supination. Active, again, 6 weeks post-op, 6 weeks post-op. Just remember that number if you see any patients with bicep tendon tears or repairs, and tears. Because remember, it was 3 weeks, and then 3 weeks. So that's true for them too, if they were non-operative. Strengthening should start at 8 weeks. Okay, so resistance not until 8 weeks. Recognize that their endurance and their strength is likely going to be decreased with supination. So what the research says is a 47% decrease in endurance and a 21% decrease in strength into supination. So I don't know what jobs out there really use a lot of supination, but if that happens to be their job, or if they really love to play something like badminton, or maybe even table tennis, where they need to have a lot of supination strength and endurance, you may be working really hard with them to try to get it because they may be really struggling with those types of activities. So 6 weeks, we're doing active range of motion, elbow flexion, supination, pronation. We can start progressing to submaximal isotonic exercises. So a little bit of resistance into elbow flexion, supination, pronation. And then at 8 weeks, we can actually start adding more light resistance or light weight. So, I would say between 6 and 7 weeks, you can actually do more isometric exercises. So you can have them do, resistance without movement, just submaximal resistance without movement, and that should be okay. And then at 8 weeks, you can start doing movement with resistance. So again, light weights, TheraBand, that kind of thing. Keep up the scar and soft tissue mobilization. That needs to be a big part of treatment. So you'll see here, these are some examples of ways that you can do resisted and controlled supination and pronation. So you can, they made sort of like a big giant hammer here with a weight and a stick. So you could certainly make something like that, get creative with that. A hammer itself works really well. Actually, this kind of looks like a hammer, and a hammer works really well. What else? We use like water bottles with like the longer head, like the neck of the water bottle, so that you're holding onto the neck of the water bottle, and the bottom part of the water bottle is what moves back and forth. And that tends to work really well too, because again, that heavy piece is more distal. And then with this one, they attached a TheraBand to something. I don't know if that's it almost looks like a hammer, but I don't think it is. I think it's just a stick. So that's another option for resistance. Again, remember, TheraBand and weight definitely add different kinds of resistance. So consider using both. And then she's doing bicep. You can see she's doing flexion, but then including supination and pronation. So flexion with supination, flexion at elbow flexion at neutral, and elbow flexion with pronation. And you do want to do all three of those to, again, put different amounts of strain, different things, different amounts of resistance on that distal bicep tendon. So at month 3 to 6, we can start doing more sport-specific training and more resistance. And so with this one, you really want to be careful that you're not too aggressive. So at 3 to 6 months, you can start doing, again, testing the patient and see how they do. If their strength is pretty good, especially with combinations of supination and flexion, you can start really getting back to return to sport activities. But it's interesting. One of the things they really suggest is to not do jogging. So they really say that you don't want to do running. And none of us think about the fact that we are literally in elbow flexion for most of the time. If we're running correctly, we're in elbow flexion, and there might be even a little bit of supination, pronation happening with running. And so they suggest that you wait at least until 3 or 4 months after surgery before you start jogging. So we want to keep up the cardiovascular activities. I love this picture. I just think this guy's so funny. He has big biceps, that's for sure. Cardiovascular activities, always important. I mean, you could start cardiovascular stuff, right? Like day 2, so that's easy. Progressing strengthening. Start doing plyometrics, but don't really return to contact sports. Anything where you may have to push somebody away, seriously, until about 6 months. So that's probably where you're going to have the most resistance, right? Is if you have to kind of get off of somebody or get out from underneath somebody. So you want to wait on that until 6 months. So that's bicep tendon rupture and repair. Again, there's just a couple rules you want to follow and timelines you want to know about. So there you go.